Hello friends, welcome to King's Crux, and today we will look at a very important topic to consider, that is optic disc changes from glaucoma. It's going to be a complete comprehensive review. We will start to look at how a normal optic disc will look like, and from there we'll go for a slow transition to how an optic disc in a glaucoma will look like. So step by step, level by level, we will understand what the topic is, and I would like to dedicate this lecture to my favorite professor out there, Dr. George Sir, the Chief of Glaucoma Services at Aravind Hospital, Madurai. So with that, let us jump to our topic. Now, before I delve into the details of the topic, now I just want you guys to consider this resemblance to a movie. Okay. Now here we have a very happy-looking normal disc. So things are all fine, things are all very happy there, and until the villain of the movie comes into play, the villain is glaucoma. Okay, so when the villain comes into play, things are not going the right way, so the disc is not happy. So we will discuss what are the features, the anatomy of a normal looking optic disc. Okay, and from there we will introduce the villain of the film, that is glaucoma. So we will define what glaucoma is, we'll build a concept called glaucoma, we'll take a break from there, and then we will see how an abnormal glaucomatous disc will look like. Okay, so let us go for the normal concepts first. So we'll start from the scratch. What is the normal anatomy of the optic nerve? Now this is going to be the intraocular part of the optic nerve, that is the optic nerve head or optic disc. That's the first part. Then there's the second part, that is intraorbital part of the optic nerve, which is the longest part. You have the intracanaliculaire and the intracranial. So there are four parts of optic nerve. Okay, the shortest is the intraocular, which is our important concern. The longest is intraorbital. So as we all know that there are going to be the retinal ganglion cells, which is one of the important cells in the 10 layers of retina. The ganglion cell is going to give its axon. The axon is going to travel on the retina. It's going to take a 90-degree turn. It's going to go through retina, choroid and sclera. As you can see, this is retina and this is the choroid, and then you have the sclera. So the axon of a retinal ganglion cell is going to cut across these three structures, retina, choroid and sclera, and is going to form the optic nerve. There are around 1.2 million axons of retinal ganglion cell which forms the optic nerve. A very, very important MCQ to be asked. So that is the microscopic structure of how an actual optic nerve is comprised of. Okay, so with that, just come back to this fundus picture. Now this fundus picture, okay, of the right eye explains something very important. This is the topographic view, and what actually happens is going to be the retina, just what we see is retina. The retinal ganglion cell axons are going to come from all around, and they're going to converge into this optic disc. This optic disc is the superficial portion of the optic nerve. That's what we see. So it's like a whirlpool. It's like a whirlpool where all the optic nerve fibers will eventually converge into this optic disc. So that is the concept you have to understand. Okay, let us just focus this now. We'll just focus this area, and just imagine the optic disc to be like an egg which is cut into half, and you can see this structure. You can see these structures very clearly. Now you can see this part, this margin. This is the actual optic cup or disc. What do you call this? This is called as the optic disc in its entirety. So this is going to be the disc margin. Okay, and what you see inside this part is going to be the cup. So this is going to be the cup margin. And this white portion, what we see in between, is nothing but the nervous tissue. Okay, and this nervous tissue is called as the neuroretinal rim. Okay, so which means it comprises of the nervous tissue. In other words, nothing but the retinal nerve fiber layer extending into the optic nerve. So it's an intrapapillary extension of the nervous tissue or retinal nerve fiber layers into the optic disc. It's called a neuroretinal rim. So whenever we talk about an optic disc, always imagine an egg. It will save a lot of time for us to understand. Okay. So now we'll go for the actual topographic anatomy. As I just discussed, you have an optic disc. Okay. And you have an optic cup. So disc is outside, cup is inside. Actually speaking, you look from the side, this is going to be, the optic cup is going to be a physiological depression, just a physiological small depression, okay? And this part is the optic disc. And what you see between this optic disc margin and the optic cup margin is going to be the neuroretinal rim. This part, this red colored portion is what we actually consider as a neuroretinal rim. And this depression is what we see here. And this depression is at times filled with, not at times, it's filled with some glial tissue inside. And that kind of gives a very pale appearance here. So you have a pale compartment that is the optic cup, and you have a very orangish or pinkish compartment that is a neuroretinal rim. And this entire structure is called as the optic disc. Very, very fundamental, very, very basic. Okay, so now we will take for the dimensions. The actual area of the optic disc is going to be 2.5 mm square, and there's a lot of variations. Lots of variations. It can extend almost from 0.7 to 3.5 to 3.6, which shows that the disc will come in. The disc comes in so many types and so many sizes. The diameter, the actual diameter in average is 1.5 mm, which is also the one disc diameter. Okay. But let us go a bit detailed. If we go there, the horizontal diameter is going to be 1.7 mm, whereas the vertical diameter is going to be 1.8 mm, which means the vertical dimension is a bit more when compared to the horizontal dimension. In other words, the optic disc is vertically oval. Okay, the optic disc is vertically oval. Okay. So, as I just mentioned, the optic disc, you can see here, it is vertically oval, like an egg which is kept on its longer axis like this. But just look how the cup is. Just look here. The cup is not vertically oval, but it is more of a horizontally oval. So, what is the implication of the vertically oval optic disc and the horizontally oval optic cup? The importance is very, very clear, because as you can see, so this is going to be the disc and this is going to be the cup. Okay, since because of the difference in their diameters, this contradicting dimensions of the disc and cup, one can notice that this tissue, which is in the superior aspect as well as inferior aspect, that is the superior and the inferior neuroretinal rim, they are thicker, whereas the temporal and the nasal ones are thinner, which brings us to the rule that the inferior neuroretinal rim is the thickest, followed by the superior, followed by the nasal, followed by the temporal. And that is what we call it as isn't rule. The isn't rule states that the inferior and the superior, in other words, the poles of the optic disc has the maximum axonal density or maximum neuroretinal rim, which is a very, very important concept to understand. And we will see the importance of this in the glaucoma disc section later in our lecture. So with that, please remember the disc is vertically oval, the cup is horizontally oval. So the disc should be vertically oval, the cup is horizontally oval, and if the cup is going to become vertically oval like this, it is indicative of a glaucomatous disc damage. In other words, when the superior and the inferior neuroretinal rim is going to get thinned out, if there's going to be a loss of the neuroretinal rim superiorly and inferiorly, that is indicative of glaucoma. Very, very important to keep in your mind. Okay. Now let us look at the 4 layers of optic nerve head. Now, Starting from retina to choroid, you have 4 layers. First layer is the surface nerve fiber layer. Second is the prelaminar. Third is the laminar, and fourth is the retrolaminar layer. Now, surface nerve fiber layer is on the top. Okay, it covers retinal portion, whereas a prelaminar layer corresponds to that part of the optic nerve which cuts through the choroid, this area. And laminar layer corresponds to that part of the optic nerve head which cuts through the scleral laminar pores, that's lamina cribrosa. So you can see the bundles of axons which cuts through this lamina cribrosa. And the fourth part is the retrolaminar part, from where the myelin sheath is going to start covering the optic nerve. This is the fourth part, retrolaminar part. So we have the 4 layers of optic nerve which we need to understand. This picture shows various supportive structures of the optic nerve head. Now, a lot of them are named ones, and here we can see some of them. Here we can see the internal limiting membrane of Elschnig, which is a continuation of the internal limiting membrane. And the central part occupying the optic cup is the meniscus of Kunt. And we have 3 important glial tissues which are going to border at the sides, namely the intermediate tissue of Kunt, border tissue of Jaypee, and border tissue of Elschnig. The most important supportive structure which we have to understand is lamina cribrosa. They are not just the pores in the sclera, but they are nothing but the glial tissue filled tissues, okay, which have the pores. Through those pores, the bundles of axons of the retinal ganglion cells will pass through. Now, if I'm going to take a cut section at this level, I'm going to take a cut section across the scleral lamina cribrosa, what I will be able to see is this. Now, just look at this. These are the pores. As you can appreciate, the size of the pores are larger in the superior as well as the inferior part of it. Okay, so superiorly and inferiorly, the pores are large. When the pores are large, which means they accommodate a larger size of the axons. When the size of the axons are large, there will be less glial tissue will be there. And this less glial tissue support is responsible for more damage that occurs in a glaucomatous condition. And that's why we always say the superior and the inferior parts of the neuroretinal rim, or the superior inferior parts of the axonal bundles, they are more prone for glaucoma. That is very important, and that's why let us make a statement that the lamina cribrosa is the main site of glaucomatous damage. What about the optic nerve blood supply? Optic nerve head, not the optic nerve, but just the optic nerve head, has basically 2 types of circulation. One is the retinal circulation. The other is the ciliary circulation. The retinal circulation occurs by the central retinal artery and its branches. The ciliary circulation happens with the help of the ciliary arteries. Okay? To be more precise, the short posterior ciliary artery and its branches. The central retinal artery is going to cover the retrolaminar part of the optic nerve head and the superficial nerve fiber layer, the both ends of the optic nerve head. Whereas the ciliary artery supplies all part of the optic nerve head except the surface nerve fiber layer. Very, very important. Which means the short posterior ciliary artery is going to supply the prelaminar, the laminar, and the retrolaminar parts of the optic nerve head. Okay. Now, this is a very important schematic diagram to show the same. Now, we have the surface nerve fiber layer, the prelaminar, laminar, and the retrolaminar. This is the central retinal artery which is going through the optic nerve, and this is the short posterior ciliary artery sending its branches to sclera, choroid, and retina. Now, as I just mentioned, the central retinal artery is going to give its branches in the retrolaminar areas and in the surface nerve fiber areas. Whereas the short posterior ciliary artery is going to give its branches to the laminar, to the retrolaminar, and to the prelaminar areas. Very, very important. Okay. To add more details to it, the short posterior ciliary artery is going to form an intrascleral plexus, or a circle of arteries called as circle of Zinhaler. Circle of Zinhaler. Okay, so this circle of Zinhaler also gives its own branches to the prelaminar, laminar, as well as to the retrolaminar. Okay, yes, and also the short posterior ciliary artery is going to give its branches to the choroid as well. So it's called the peripapillary choroidal branches are also being given. Okay, so this is the basics of it. This is the basic structure of the blood supply of the optic nerve head. And let us look at some of the pictures here. As you can see, the posterior ciliary artery, we have the central artery. The posterior ciliary artery is going to come, to be more precise, these are the short posterior ciliary arteries, which are branch of the posterior ciliary artery, and this artery forms the intrascleral plexus called as Zinhaler, and the Zinhaler is going to give its blood supply to the prelaminar, laminar, retrolaminar areas here. Okay, whereas the central artery is going to give to the retrolaminar region, and not just that, they also give branches to the nerve fiber layer of it as well. And then, of course, it's going to be anastomosis between the posterior, the ciliary artery circulation as well as the central artery circulation. And this picture again shows the same. Here we have the ophthalmic artery. The ophthalmic artery, okay, which is a branch of the internal carotid artery, is going to pierce the optic nerve. Okay, it's going to pierce the meningeal sheath, enter the optic nerve as central retinal artery. Central artery supplies the branches to the inner part of the retina. Whereas you can see the short posterior ciliary artery again going up, entering or piercing the sclera, okay, and forming the circle of Zinhaler. They also form the peripapillary carotid arteries when they enter the choroid. Okay, and also these pile vessels are there. The pile vasculature, which are branches from the ophthalmic artery or from the central retinal artery, they also supply the optic nerve head as well. So, to summarize, understand this, very important. The retinal nerve fiber layer receives blood supply exclusively from the central retinal artery alone. Okay, that is first point to be noted. So the prelamina and the lamina criprosa regions receive blood supply from exclusively ciliary arteries only. Okay, whereas the whereas the retrolaminar part of the optic nerve receives blood supply both from the retinal as well as the posterior ciliary artery, as just mentioned in the very first discussion of our blood supply. So this is the blood supply of the anterior part of optic nerve or the optic nerve head. Very, very important concept to understand. The reason being, the branches of the short posterior ciliary artery are most often the end arteries. So because of end arteries, they are more prone for ischemia. So there is ischemia, there's going to be a perfusion, reperfusion damage which occurs especially in glaucoma and other conditions as well. And also, when there's going to be a raise in intraocular pressure, that is going to cause a reduction in the perfusion pressure. When there's going to be a reduction in perfusion pressure, there's going to be a reduction in the ocular blood flow as well. Therefore, a reduction in the ocular blood flow or reduced perfusion of the optic nerve is very much implicated in the pathogenesis of glaucoma. Okay, now let us understand the topography of retinal nerve fiber layer. Very, very important. This is going to be the optic disc and this is going to be the macula. The retinal nerve fiber arising from the macula going to the optic disc are pretty much having a very straight course. The course is very much straight. And this part is called as PMB, also called as papillomacular bundle. Papillomacular bundle. Okay. Now, from the other parts of retina, the fibers are going to come like an arc, like this. Okay, now this is called as arcuate fibers. These are called as arcuate fibers, and these are superior arcuate fibers, and these are inferior arcuate fibers. The arcuate fibers is the term which we use given to the fibers which are seen temporally, temporal to the disc. What about the nasal ones? The nasal ones, okay, the nasal ones are also going to come not much of an arc, but more of like a radial fashion. So these are called as superior nasal radial fibers. These are called as inferior nasal radial fibers. Okay. The importance of this is, again, as you can see in this picture, you can see this is going to be the optic nerve head, and you can see the superior nasal radial fibers. These are the inferior nasal radial fibers. Okay, and this one is going to be the superior arcuate fibers. These are the inferior arcuate fibers, and this is going to be the fovea, and whatever we're going to see here is going to be the papillomacular bundle, and this is the horizontal raphe, or the demarcation between the upper and the lower retinal hemispheres. And this is another important picture to show the distribution of the retinal nerve fibers within the optic nerve, okay, which is very, very simple, very simple. You have a peripherally located ganglion cell, you have a centrally located ganglion cell. Let us keep this ganglion cell as the starred one. This is this diamond shaped ganglion cell. Let us keep it as A, let us keep it as B. Okay. Now the retinal nerve fiber which is arising from the ganglion cell A, which is located more of a peripheral to the optic nerve. Just trace this where they enter. They enter in the outer part of the optic nerve, or in the periphery of the optic nerve. Whereas you take this from the ganglion cell B, which is more often located near the central part of the optic nerve. It's more close to the optic nerve, and the axon arising from this ganglion cell is going to be lying inside or in the center of the optic nerve. So the peripheral axon in the retina goes peripherally in the optic nerve. The centrally placed axon and its the centrally placed ganglion cell and its axon are going to travel central in the optic nerve. The implication being the arcuate fibers are most sensitive to glaucomatous damage, and that's why very early in glaucoma we can see the arcuate scotomas, which we will discuss in the further lectures of visual fields. We just know that the most sensitive fibers are arcuate fibers, the most resistant fibers are the macular fibers. And very importantly, as I just said, any damage in the ocular disc, in the optic disc, okay, we can localize that to the visual field defects. Which means, just look at this example. Now here we have an optic disc, here we have an optic disc, and this part of the optic disc is damaged. When this part of optic disc is damaged, the corresponding retinal nerve fiber layer is also damaged. And the part or the visual field which is mapped by this part of retina will be marked here. So a damage which is located in the infero temporal part of the retina is manifested as a scotoma, is manifested as a visual field defect in the superonasal field. Okay, so what is so far we have learned something, that a glaucoma is a condition where there's going to be a rise in IOP, which we always know that. Now we know that the optic nerve is damaged as well, and visual fields are also affected as well. Okay, but the question is, why does it occur? Why does a glaucoma should occur? The two theories are basically given. One is a mechanical theory, the other is a vascular theory. Easily put, there is going to be a mechanical damage which occurs because of a rise in intraocular pressure, and that rise in the intraocular pressure causing mechanical damage is going to impair or intrude the axoplasmic flow. When the axoplasmic flow is going to be impeded, and that is going to cause the apoptosis of ganglion cell death. Okay, just understand, there is going to be an interruption of the axoplasmic flow or in the nerve transport in the optic nerve head, and that is going to go and damage, or it's going to cause the death of the ganglion cells. Okay. The second one is going to be the ischemic theory, which states that the reduction in the optic nerve head perfusion causing ischemia again is going to cause an insult to the axoplasmic flow, and that again is going to cause apoptosis of cell death. The apoptosis of the ganglion cell is the eventual or it's going to be the final destination in glaucoma on a histopathological level. Okay. So now, having known the concept of what is glaucoma, let us define what glaucoma is. Now, glaucoma is a chronic and a progressive disease. It's a chronic and a progressive disease which is characterized by irreversible optic neuropathy. The nerves once damaged in optic nerve cannot be reversed back. There are some exceptions, but most commonly it is an irreversible optic neuropathy which is having very typical optic nerve changes. You cannot attribute these optic nerve changes to any other diseases. They are so much unique to glaucoma. And because of the optic nerve disease and because retinal nerve fiber layer defects, they have a corresponding visual field defects the patients will experience. And as we all know, there is going to be a rise in IOP, but not always. There can be a rise in IOP, there can be a normalcy in the IOP as well. But the more important point to understand is that this rise in IOP is probably the only modifiable risk factor, which means it is the only way where we can try to control the progression of glaucoma. So, be it our medical management, be it a surgical management, both of them aim to control the intraocular pressure, which is the only modifiable risk factor in glaucoma. So far, we have discussed what is going to be the normal anatomy of the optic nerve head. We discussed about the blood supply of the optic nerve head, and we discussed about some elements of glaucomatous damage, how it can occur, by discussing about the visual field defects for some time. And now we take a break. So far things have been very happy. We have seen a happy looking disc, and we just kind of introduced the villain to the picture, the villain being glaucoma. And with this break, let us go for the next part of our lecture, that is the optic nerve head changes in glaucoma. What are going to be the optic nerve head changes? Very easily put. We have the optic disc, okay? So, and we have the blood vessels here. So whatever changes which is going to happen within the disc, there is the papillary changes, and the change is going to happen because of the disc changes. The consequent vascular changes are going to be the next part of the discussion, and whatever is going to happen surrounding the disc, be it a hemorrhage or be it a scar, that we'll discuss under the peripapillary changes. So we'll take it one by one, step by step. So under the papillary changes, we'll discuss the size of the disc, the shape of the disc, most importantly the neuroretinal rim and its characteristics in glaucoma. We'll discuss about the color of the disc, and we'll discuss about the asymmetry of the discs as well. So size of the disc. Just like human beings who come under different shapes and sizes, optic discs also come under different shapes and sizes. So in this picture, it is very evident that optic disc can vary from a very small disc to a very large disc. The importance being, a glaucomatous damage might be underestimated or it might be underlooked in a small disc. Whereas in a larger disc, we might think it is glaucoma, but it might not be a glaucoma. So we need to know the importance of both. So it is very easy to diagnose a glaucomatous damage in a large disc because everything is large, everything is well visualized. There are large axons are also going to be there. Okay, whereas in small disc, because the crowding of the disc, it is not always possible. As you can see in this picture, this is going to be a physiological normal disc. There's a physiological cupping, which means the CDR is more, the CDR is 0.7, but it's physiological because you have a normal healthy neuroretinal rim is there. Okay, that's what HNRR means. But look at this smaller disc. Have a look at this smaller disc. In this smaller disc, okay, there you can see a presence of an early notch here. You can presence of an early notch. You can see a notching at this area. We'll discuss what a notch is later. But just know that in this small disc, there is going to be a glaucomatous damage, and you can also see a corresponding retinal nerve fiber layer defect as well. We will discuss about this also later. Just know that small doesn't mean that small means that you can easily miss out a glaucomatous damage, so be careful with that. Another question frequently asked is, how will we measure the size of the optic disc? There are two ways. One is by using a Welch-Allen direct ophthalmoscope, because a particular part of the direct ophthalmoscope of Welch-Allen, the diameter of that spot will be 1.5 mm, which is nothing but the one disc diameter. So it's very easy to measure the disc size because of that. And also, gold standard is we can use the slit lamp biomicroscopy by using these lenses plus 60, plus 78, or plus 90. We have to use the the corresponding correction factors, that is into 1, into 1.1 and into 1.3 as well. And so we will now discuss about the next part. Sometimes the size of the disc, okay, can cause a lot of confusions to us, because there are certain conditions which will mimic the small optic disc, certain will mimic the large optic disc. Most importantly, when it comes to a small optic disc, okay, very importantly, the optic nerve drusen's and AION should be kept in mind, and pseudopapillomatous conditions like hypermetropy also should be kept in mind. But whenever you see a large optic disc, always think about high myopia conditions and some of the congenital anomalies of the optic disc, like optic disc pit, morning glory syndrome, and coloboma as well, which is a very important significance. Now, as the shape is concerned, the most important thing to understand is, as far as myopia in high myopes, okay, you can have a tilted disc, you can have a very much tilted disc with a lot of crescents and with a lot of scars as well, and that is to be kept in mind. The more important point to understand is, when we take an optic disc, okay, the optic disc, we have an optic cup. The very confusing thing is, what is going to be the limitation of the optic disc? The limitation of optic disc is scleral rim. There is going to be a scleral ring or a scleral rim, also called as Elschnick's scleral ring or rim. Okay, as you can see in this picture, this white colored demarcation is going to be the scleral rim. So when we are going to measure the cup or the disc size, we have to always keep the scleral rim as the outermost extent. Okay, because sometimes we might include this as a part of or as a measurement of the size of the disc, but it is not. We should not include the scleral ring in measurement of a cup disc ratio. Okay, so it is very important to understand. So the inner lip or the inner margin of this rim will mark the extent of the optic disc. So we have discussed about the margins as well. Now we come to very important, this neuroretinal rim. I think you already seen in the first part of this lecture when we discussed about the anatomy of the optic disc. We follow a rule called isn't rule, which means that the thickest portion of the neuroretinal rim is going to be the inferior one, followed by, yes, the superior one. Then comes the nasal, then comes the temporal. So inferior rim is the thickest, the temporal rim is the thinnest. This is the isn't rule, which is responsible for the horizontally oval cup and the vertically oval disc. Okay, but when this isn't rule is damaged, or when this isn't rule is violated, that is, when the cup is going to be vertically oval, there's going to be thinning of the neuroretinal rim superiorly and inferiorly, or at the poles. So a vertical elongation of the cup at the poles is characteristic of glaucoma, and that is what we call it as a pathological cupping in glaucoma. Because cupping can be physiological as well. Cupping means just a rise and increase in the cup disc ratio. It's not always a pathological condition, but when there is going to be an increase in the cup disc ratio, especially at the poles, that is what we call as a pathological cupping exclusively to glaucoma as well. So just compare these two discs. This disc is going to follow the isn't rule. As we can see, the inferior is the thickest, followed by superior, the nasal and the temporal. But look at this disc. Here isn't rule is violated, which means you can say the thinning of the superior and the inferior discs. So when there's going to be a thinning of superior and inferior neuroretinal rim, there's going to be a damage to the neuroretinal rim. Okay, and that is evident from this picture. In this picture, just compare these two discs. This is going to be a normal one. This is an abnormal one. Okay, normally this is going to be a normal thick nerve fiber layer is there with a minimal central cup, whereas the pores are aligned with the sclera. So there's a thick, you can see very thick nerve fiber layer. There's a minimal central cup, but compare it with a very advanced glaucomatous damage, there is a thinning of the nerve fiber layer. The nerve fiber layer is thinned out, or it is defective. Okay, you can see the neuroretinal rim is also thinned out. Okay, so there's a thin NFL. There is a large excavated or a large depression in the central cup. So it's an excavated and enlarged central cup. And you can see there is a posterior and outwardly rotated scleral laminar pores. So always remember these three. These three are the typical histopathological features of a glaucomatous disc. A thinned out NFL, excavated enlarged central cup with a posterior and outward rotated pores. And this is the histopathological to show the same. You can see a large excavation of the central cup, the thinned out nerve fiber layers with the posteriorly displaced laminar pores. So we talk about cupping. A very important thing to understand is there can be two types of cupping. One, it can be a very shallow cupping. Shallow cupping is something which we might miss very often, but this is also a very important finding to be noted in glaucoma, where the cupping is mostly restricted to the prelaminar part of the optic nerve head. But a more significant, a more characteristic will be a deeper cupping that is involved in the laminar part of the optic nerve head as well. Okay, so this is more significant of glaucoma than the shallow cupping. It's just one important point to remember. And again, a cross section of the optic nerve just shows there's going to be atrophy at the superior and the inferior parts of the optic nerve. This is going to be the normal one. This is going to be a glaucomatous damaged optic nerve. Just shows that the importance of looking at the poles. Okay, just see these two discs. This is disc A, this disc B. The disc A, we can see the cup disc ratio will be, I will say, like 0.4 to 0.5. You can see a very healthy neuroretinal rim. The same can be told for this. You can see a very healthy rim here. But what happens here? Is it healthy? No. There is complete loss of the nervous tissue. There's a loss of neuroretinal rim at this area. So we cannot call this as 0.5 cupping. Okay? Because the rim superiorly might be very thick, looking good, but inferior is lost. That's why we should always consider what is the rim diameter. The rim diameter or the contour of the rim is of great importance. So it's not just about the cup, it's about the rim. It's not about the cup, but it's about the rim. Always keep this in mind. So cupping means there's going to be a rise or there is going to be a larger cup disc ratio. So cup is occupying a more area in the optic disc. That's what cupping means. So cupping can be either a physiological cupping or it can be a pathological cupping. Okay. So as just said, a larger disc might have a larger cup. So always you should consider the size of the disc as well. So that's a physiological cupping is very, very common. Pathological cupping can be either glaucomatous, can be non-glaucomatous. Glaucomatous is what I told, there's going to be a vertically elongated cup, okay, which is characteristic, vertically elongated, especially at the poles, okay, that is glaucomatous cupping. Non-glaucomatous cupping can happen in conditions such as arthritic ischemic optic neuropathy, okay, anti-ischemic optic neuropathy, okay, that can happen there and can happen in other congenital anomalies of the optic disc, namely glaucoma of the optic disc, okay, namely morning glory syndrome, megalopapilla or larger size, as we just discussed in physiological as well. So the point to understand is the cupping is not just unique to glaucoma. Cupping can be either physiological or it can be a non-glaucomatous conditions as well. And bearing those conditions in mind is very important when we diagnose a glaucomatous damaged optic disc. Okay. So there are three patterns of glaucomatous cupping. The first, there can be a diffuse or a concentric loss of neuroretinal rim, or there can be only at one pole, as we can see here, or there can be at both the poles as well. So knowing that this is a unipolar and this is a bipolar. Okay. Whereas notching is the term we use for a focal loss. This is going to be a normal disc. This is going to be a disc which has a notch. So notching is a small excavation at this area. So there's going to be a focal notch. And all this focal notch might have a corresponding retinal nerve fiber layer defect, which we'll discuss later. And it also might have a corresponding hemorrhage in the retinal nerve fiber layer as well. So some important points to consider. So always understand, noting down the notch is very important. We might easily tend to miss out the notch because we'll just look at this part. We think, okay, this is a very healthy looking. But look at this part, this is not so healthy looking. Okay. Another important feature of neuroretinal rim is called saucerization, which happens in glaucoma. Saucerization is the term we use for a shallow cupping but with a retained central cup pallor. The central cup pallor is maintained. Central cup looks normal. This looks like healthy, but there's going to be a very shallow cupping, as we can see. Okay, and just consider this again. In this picture, okay, in this picture, we can see that the margin of the pallor, the cup margin is there. There's a margin of the pallor, so we can see two margins. In this cup margin, the cup margin is extending down, so there is a loss of neuroretinal rim, a loss of this tissue inferiorly. But if you want to consider the pallor of the cup, it's extending up to here, and the color between the pallor margin and the cup margin is going to be normal. So there's a retained normal neuroretinal rim color. There's a focal area of saucerization here, and this area is called as tinted hollow. Okay, very important thing, because very often beginners, when they try to diagnose a glaucomatous cup, they often look at only the color or the pallor of the cup. They just think, yes, the pallor is extending only till this. So they put the CDR as, say, I would say, they'll put it as 0.6 or 0.7. They'll call it as healthy neuroretinal rim. But in fact, when we have a focal defect here, we cannot call this healthy neuroretinal rim. There's a saucerization. There is a focal area of loss of the rim is there, and therefore it is very, very important for us to always think about this and make sure that you always follow the contour of the cup rather than the color of the cup. Okay, so following the contour, following the dimensions is very important again. And this picture shows again is going to be the kinking of the blood vessels at the disc margin. So this picture shows again the saucerization here. And we can compare the different cups and their morphologies here. So there's going to be a normal physiological cup. This is going to be a very shallow saucerization of the cup. And this part where you have a kind of a sloping on one end, what we call as a shelving. And here you have an excavation or a loss of the neuroretinal rim or the tissue. So this is going to be a unipolar excavation. This is going to be a bipolar excavation of the cup. Okay. So when there is going to be a recession of the neuroretinal rim, when the neuroretinal rim is going to get lost, get disappeared, and that exposes the lamina cribrosa pores, which you can easily see in the optic cup region. That is called as the laminar dot sign. As you can see again, this picture showing the multiple small dots. This is the laminar dot sign. When there's going to be a completely excavated optic disc, where there's going to be complete excavation of neuroretinal rim, where you do not see any neuroretinal rim elsewhere, that's what we call as a bean pot cupping. Where there's a deeply excavated cup, the deeply excavated cup is going to be there. Okay, and that gives a very much an atrophy appearance, what we call as a glaucomatous optic atrophy. Okay, or also called as the cavernous optic atrophy. Now, because of such a excavation of this area, I'll just place the vessel here. The vessel is going to come up. It is going to take it's going to take a turn like this. So vessel has to climb all the way like this and take a turn. So that will give a very characteristic kinking of the vessels. As you can see, the part of the vessel is not seen here. It's kind of obscured here. Okay. So that is what importance of bean pot cupping. So which resembles like a pot, and this is a histopathological picture to show the same. As you can observe, the kinking of the blood vessels here. Yes. Now we'll come to the color of the cup. To be more precise, the color of the neuroretinal rim. The cup is always paler. Cup is normally it is pale in color because of presence of glial tissue there. Okay, and you don't see much of a nervous tissue there. The color of the cup is going to be pale when compared to the neuroretinal rim. So the color of the disc implies color of the neuroretinal rim. That is the first point to be understood. Okay. Normally the color of the neuroretinal rim is going to be healthy pink in color, pink or orangish red in color. It is a normal color. But whereas when there's going to be glaucoma, okay, the more of a cupping is seen. The cup is more, the cup size is more. Therefore, we look as if the pallor is more. But in fact, the pallor of the neuroretinal rim is not there in glaucoma. But when you have a pallor of the neuroretinal rim, that is indicative of a non-glaucomatous optic neuropathy damage. So pallor more than cupping indicative of a non-glaucoma. This cupping more than pallor, it is indicative of glaucoma. Very, very important point to understand. So in this picture, as just mentioned, we may think the demarcation is going to be only till this. Okay, so I would say, okay, so look at the pallor of the cup. So pallor of the cup is here, and this is going to be the disc margin. So I would say the cup disc ratios would be say a 0.6 or 0.7. But look at this. Look at very closely. You can see the vessels. The vessels are going to kink here itself. Okay, so the actual cup size is larger, and you can see a small notch also here, which again shows that the cup size is larger than the pallor. So this is going to be a glaucomatous damage. So never ever look at the pallor. Do not judge a disc by its color. Always judge a disc by the contour or by the dimension or by the extent of the neuroretinal rim, not by the color of the cup. Very important. And again, we might get lost because we just see the fundus of one eye. We might not even remember to see the other eye as well. So always looking for the other eye is very, very important. Not just any patients for that matter, not just in glaucoma. Any patients looking at the discs of both the eyes is of prime importance, because when it's going to have an asymmetry or a difference or dissimilarity in the cup disc ratio, it is always suggestive of a glaucomatous damage. And they say when there's a more than 0.2 cup disc ratio, we should always think about glaucoma. As very evident from this picture. In this picture, the cup disc ratio will be say around 0.4 or 0.5, I would say. But here, the cup disc ratio easily is 0.7 to 0.8. So there is a more than 2 difference, and that is suspicious of glaucoma as well. And also you have an inferior, a notch is also seen here. So disc asymmetry is not just between the asymmetry of the cup disc ratio, it's also between the size of the cup, the width of the neuroretinal, that forms a cup disc ratio, the vessel course, and peripapillary atrophy as well. In this picture, you have this right eye, you have a left eye. The left eye looks healthy, whereas you can look at the right eye, there's a stark difference. One is going to be a larger cup is there, so the cup disc ratio is more. Okay, the size is larger. There's going to be a thinning at the inferior pole, which is not very evidently seen. It's going to be a thinning of the rim at the inferior pole. You have a corresponding peripapillary atrophy here as well. A scar is also seen here. Okay, which suggests of that we should always suspect glaucoma in this patient because of the marked asymmetry or marked dissimilarity between the disc sizes and disc features. So as I was mentioning till now, looking at the rim, looking at the characters of the rim is of prime importance, and that's why more than the cup disc ratio, going for a rim disc ratio is very important. That is, we consider what is the diameter of the rim to the disc. We're not bothered about the cup, but we are concerned about the rim. So rim diameter is the key, and we make use of this rim diameter in the scale called as disc damage likelihood scale, or DDLS. So just to note that there are 10 stages in DDLS, okay, where we classify the discs into at risk, glaucomatous damage, and glaucomatous disability, okay, ranging from a very healthy rim disc to a complete loss of the rim disc as well. And this scale is of more practical, more clinical significance when compared to normal cup disc ratio. So far we have discussed about the papillary changes, that is the changes which happen in the vessels, and now we'll quickly move on to the vascular changes. Okay, the concept of vascular changes is very, very easy. Now consider this. This is going to be a normal optic. This is going to be the normal optic disc with a physiological optic cup. Okay, so you have a depression here. So whenever the blood vessel is going to come, they're going to come out and they're going to lie in this area. But when there's going to be a cupping here, say an excavated cup is there, a large cup because of a glaucomatous damage, the same vessels which are going to come up, they find it very difficult. So they have to go along the slope, along the border, and they have to reach up to the retinal nerve fiber layer. Okay, so this is the reason why we have or we see vascular changes on the disc. Okay, We'll see what are they one by one. Normally itself, when the vessels arise, they are going to be seen nasally rather than temporally. And this nasalization of vessels is more marked in a glaucomatous damage where the vessels are being pushed nasally rather than temporally. So temporally, you can see a very clean area, but nasally only all the vessels are there. But understand, this nasalization of vessels is not very specific. As you can see in this picture, where you can see a large disc is there. The disc is very large, but there is no glaucoma. There is the large disc with a nasalization of vessels, but no glaucoma. This one has an advanced glaucomatous disease, but you have vessels in the temporal aspect as well. So there is no nasalization, but there is advanced glaucoma, just to show that nasalization is not very specific finding. Sometimes there's going to be a displacement of the central trunk as well. When the central trunk is going to come up, there's going to be a normal disc where the central retinal vessel trunk is going to come. But when there's going to be a displacement of the trunk from the central position to nasally, that is also a very important indicator of glaucoma. Binating is the word which we use to refer the knives in the old rifles. So you can see a sharp edge is going to be here. So as I just mentioned, the vessel has to climb along this steep margin of the optic cup. So they have to climb up and go. So similarly, as we can see, the blood vessels have to come. They have to rise against the steep margin of the cup. They have to come. So that kind of gives a kinked up appearance of the blood vessel. That's what we call the name as binating. Bearing of circumlinear vessels is another important feature, what we call as a BCLV. Circumlinear blood vessels are branches of central retinal artery. Okay, usually these circumlinear vessels are going to go along the margin of the optic cup. So they will be at the cup margin. Whenever there's going to be a recession of the neuroretinal rim, when the cup becomes larger, okay, this is going to be how the vessel is going to come up. So this is the vessel which are going to just outlining the cup margin. Since the cup margins have receded, this is how the vessels are going to be. So there is going to be a bearing of the sclera, or bearing, not the sclera, yes, you can call it a sclera, or it's going to be bearing of this area of the cup. So that's called which means the normally hardly seen vessel is now bared, or it's become exposed. So this exposed circumlinear vessel is what we call as a bearing of circumlinear vessels. In this picture, you can see that there is going to be some amount of cup is remaining between the blood vessel and between the cup margin. Again, this picture is very clear. You can see one exposed blood vessel here between the margins of the cup and between the blood vessels. Okay. Because of the chronic disease in glaucoma, there is always a chance for formation of collaterals, and we should always distinguish these collaterals against neovascularization of the disc, especially in advanced neovascular glaucoma. Okay, with the help of fundus fluorescence angiography, they have to be distinguished. But always note, formation of collaterals is another important finding as well. So far, we have discussed about the papillary changes and the vascular changes, and now we'll discuss the changes which happen surrounding the disc. So we have three changes actually. First, the retinal nerve fiber layer defects or changes there, hemorrhages and peripapillary pigmentations. We'll take it one by one. Retinal nerve fiber layer, nothing but the striations which are very shiny, which are very thick striations which we can see when we look at the fundus. They are more prominently seen superiorly and inferiorly, that is superior-temporally and inferior-temporally. You have nasally also. We can also see the RNFL in the papillomacular bundle as well. So these are the radiating nerve fibers, which is most commonly seen at the poles. So whenever there's going to be a defect, whenever there's going to be a damage to the nerve fiber layer, that will be appearing as defects. Now this is a normal thick retinal nerve fiber layer, which is characterized by like white striations. These are more commonly or more easily seen under red-free filters or under black-white photos. So this is a healthy RNFL which is going to obscure the blood vessels. You can see a very healthy thick retinal nerve fiber is kind of obscuring blood vessels here. But when there's going to be a defect in the retinal nerve fiber layer as a wedge-shaped focal retinal nerve fiber layer defect, you can see the darker areas here, and it is more easily seen in the red-free filters as well. And very important to note that the notch will always follow, most of the times, will follow the retinal nerve fiber layer defect. As you can see, there's going to be a notch here, a notch, and also a notches here. So whenever there is a notch, you can see corresponding retinal nerve fiber layer defect is there. Okay. So having finished the retinal nerve fiber layer defects, let us discuss the disc hemorrhages. These disc hemorrhages are very important because they are very early, they are very easy to miss. These are retinal nerve fiber layer hemorrhages, just like a splinter hemorrhage which we will see in diabetic retinopathy or hypertensive retinopathy. These are splinter peripapillary hemorrhages, and we give a different name for this called as a Drans hemorrhage. Okay, so some important features are, as just said, it's an early sign of glaucoma, and hemorrhages will always come first or they precede the disc damage and field defects. They're very common in normal tension glaucomas and in diabetes mellitus patients with glaucoma. The most common site is the inferior quadrant, and they will follow notch and the defect. So when you see a notch, you can see a defect in the RNFL, and also you can see a hemorrhage. So again, this shows the hemorrhage here. Okay, you can see the hemorrhage and the inferior part. And there's multiple photos again showing clearly there's going to be a notch, there's going to be a defect, there's going to be hemorrhage. Again, it's very easily seen in red-free filters here. And again, this shows retinal nerve fiber layer defect here. You can see multiple RNFL defects here as well. So we have discussed about the hemorrhages, we discussed about the RNFL defects. Now we'll talk about peripapillary changes here. So when I say peripapillary changes, changes that happen surrounding the optic disc. Now this is going to be the optic cup, and this is the neuroretinal rim. And as we previously discussed, the demarcation of the optic disc is going to be the scleral ring or scleral lip. Now there is going to be two zones. One is zone alpha and zone beta. Zone alpha is outside, zone beta is inside, which means zone beta is nearer to the disc. Zone alpha is just outside to the zone beta. Not always both will be seen together, but both can be found together as well. So which needs to be concerned, because the clinical relevance being these are peripapillary choroidal atrophies or scars or pigmentations that can be normal, they can be abnormal as well. And these are areas of weakness, and if they are progressive, if we find a progression of these zones, they are indicative of glaucoma, and they're more commonly seen in very high myope patients, in myopias. Okay, and one important thing to remember is the gray crescents. Gray crescents, they are not a part of alpha and beta zones. They are seen inside the scleral lip, okay, which means they are part of neuroretinal rim. Okay, they should be taken as a part of the neuroretinal rim. So when we take into consideration, when we are going to measure the cup disc ratio, we should always take them into consideration. As you can see in this picture, this might look like a peripapillary atrophy, but it is not. This is a gray crescent. These gray crescents are not commonly seen in Indians, but most commonly seen in African patients. Okay, so this needs to be kept in mind. But more importantly, we have the alpha and the beta. This is the alpha and this is the beta zone. Okay, alpha zones and beta zones are at times very easily missed, because when we are not able to really see what the exact limitation, exact extent of the disc margin, it's very easy to miss. Okay, sometimes in advanced glaucomas, the beta zone can form like a halo surrounding the disc. You can see a big halo is there. This halo is the beta zone. It's called as Glaucomatous. It's one of the features. So one important thing to understand is which zone belongs to NRR, which zone will not belong to NRR. Temporal crescent, yes, it belongs to the rim, whereas zone beta and alpha does not involve the rim, but zone beta is a very important indicator of glaucoma. So when present and when progressing, glaucomatous damage can be indicated by zone beta. So far there are many signs which are going to tell whether a disc is going to be glaucomatous or not. There can be changes which can happen within the disc or with the vessels or outside the disc as well. And not a single feature is unique to glaucoma. Every feature is there when only clinically correlated with intraocular pressure and when multiple signs are going to count, they will give an indication of the optic nerve damage. And there are important signs of progressive optic nerve damage. The first and important being whenever there's a change in the contour of neuroretinal rim, a presence of a notch, or when there's going to be an enlargement of the notch, a change in position of the blood vessels, there's going to be disc hemorrhage, a change in retinal nerve fiber layer defects, enlargement of the beta zones, and a development of focal pallor of neuroretinal rim. More than the pallor, the important is contour. That's why the pallor has been put as the last one. So far, we have covered enough changes in glaucoma. Okay, so we have introduced what is the normal anatomy of the optic disc. I introduced the villain called glaucoma, and we have seen what is the rupture, so what is the calamity glaucoma has caused to the disc. Just hang on for just few more minutes because I'm just going to tell you some important advanced concepts. Now, to make things more complicated, we are going to classify the disc patterns based on glaucoma, based on the typical nature of the discs. So we have 5 types of glaucoma, or 5 types of disc patterns. First is the high myopic, second is the focal ischemic, senile sclerotic, JOA, that is juvenile open angle glaucoma pattern, primary open angle glaucoma pattern, or generalized enlarged. Okay, sounds confusing, but it is just of a theoretical importance. But some important points to consider is that when we classify or when we call a disc as a high myope type, you know how a high myope fundus will look. There will be a tessellated background will be there. The optic disc is going to be large. There's going to be a concentric shallow cupping is going to be there. There is no focal RNFL defect is there. Okay, but the peripapillary changes are very much marked. You can see large areas of atrophy is there. Okay, as you can see in this picture, this is a high myopia disc pattern where you can see the tessellated background. We can see these. The peripapillary coronal atrophy is there. You can see a large disc, tilted disc is there. So we might easily miss out glaucoma in these patients, but it's always important to consider that as well. The second is going to be the focal normal or focal ischemic, where you can see focal RNFL defects are there. That is very important point to consider. It's more seen in patients more than 60 years of age. Okay, you have a deep and steep cups are there. As we can see in this picture again, this is going to be the focal normal pressure. Okay, there's going to be mostly more than 60 years. You can see a focal RNFLD is there, a focal notch is also noted here. The third one is going to be the senile sclerotic or age-related picture. Again, seen in older patients, where we have a normal size and disc, where we have a shallow moth-eaten appearance of the optic cup. That is the age-related or senile sclerotic type of the optic disc. This one showing the senile sclerotic type, where we have again a tessellated background is always seen here. The more important, more characteristic is the juvenile open angle glaucoma pattern, where it's seen in the 10 to 40 years of age or the juvenile age group or a younger age group, okay, where they have deep and steep cups, as we can note it here. We can see an advanced glaucomatous damage in this cup, so almost 0.9 to 0.95 glaucomatous damage is there. You can see a very deep and steep cups here as well. The last one is going to be the primary open angle glaucoma. There's a generalized enlargement where you can see a diffuse and round concentric cupping will be there. Okay, there's going to be an enlarged cup is also seen there, as you can see in this picture. It's a primary open angle type. So the idea is, so far we have discussed about the theoretical aspects of these disc patterns as well. But so far, if you have not paid attention to whatever I've told, whatever I've discussed, just noting these important clinical pearls is going to be sufficient. First and foremost, document the progression of changes. Always when a patient comes to me at the first visit, it's always important to make them follow up after a couple of months and noting them how the changes are going to be there at disc as well. So noting, documenting, drawing, photographing the progression of the disc changes is of prime importance. Second is dilate. Always dilate the other eye and look for asymmetry of the eyes, because very often we will miss out the asymmetry of the eyes. We might be very excited about one eye, but we might forget to dilate the other eye as well. And we should dilate the other eye or any eyes for that matter only after ruling out shallow AC by gonioscopy. And diameter of the disc, that is the size of the disc, should be kept in mind when we assess the cup disc ratio, because we should always correlate the size of the disc with the size of the cup. The dimensions or the contour of ureteral rim is the importance, not the color. Okay, the message should be very clear. Do not judge a disc by the color, but by the dimensions. Then the other D is the trans hemorrhages. The trans hemorrhages and the defects of RNFL are very important. Should never miss them. And differentials always should be considered when we go for a glaucoma. We should always keep the non-glaucomatous cupping in mind and physiological cupping in mind as well. So these Ds, these 7 Ds, will provide enough confidence in diagnosing what a normal glaucomatous cupping will look like, a normal glaucomatous disc will look like. So we'll end with the very commonly used 5 R's. Look at the ring, look at the scleral ring, look at the limitations of the size of the optic disc, look at the rim, look at the neuroretinal rim, look how the rim is, look at the contour, look at the dimensions of the rim, look at the RNFL defects, look at the RNFL hemorrhages, and always, yes, the RNFL and optic disc hemorrhages should be looked, and look at the region outside the optic nerve head or the peripapillary changes. So these 5 R's to be noted. So we'll end it here. The most important thing is to know whether a disc is glaucomatous or not. So to know whether a disc is glaucomatous or not, it is very important to see at least 1000 optic discs which are normal. So only when we know what normal is, we can know what the abnormal features are going to be. So that requires deliberate practice and frequent viewing of the fundus images. Nothing more, nothing less. Because unless we put whatever we have learned till now into practice, the knowledge what we have gained will be of least significance. And that is very, very important. And with that, I would like to invite more discussions. I will try to add upon more materials in the future. Let us make this into a system of learning how a glaucomatous disc should be. And thank you so much for your patient listening. I appreciate your patience. Thanks again. See you then. Bye-bye.